And welcome to the Dr. Bob Show. We'll be spending most of this show talking about asthma, a condition where we have breathing problems. If you walk into a hospital emergency room, you'll frequently find cases of asthma, people that are coming in with symptoms of asthma. And frequently they come in for treatment, they walk out with relief, but they come back to the emergency room in another week or 2 weeks having recurrent visits to the emergency room. Why is that? Are they on the right medications? Do they know what their triggers are? Is there something they should be doing to keep themselves out of the emergency room? My guest is Dr. Phil Jones. Dr. Jones is a board-certified pulmonologist and a board-certified allergist. He'll be answering those questions for us. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about a scary increased incidence of cancer of the colon in millenniums. Why is that? And if we have time, we'll be talking about causes of a chronic cough. There are so many causes, it may be that you'll be able to find the cause of yours. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Phil Jones, board-certified lung specialist, board-certified allergist, and we're talking about asthma. Phil, welcome to the Dr. Bob Show.
Thanks for having me, Dr. Bob. This is one of my favorite topics, and I'm excited about talking about it.
So, what is asthma?
You know, it depends on who you ask. To a patient, it's cough at inopportune times. When I'm trying to play sports, when I'm trying to sleep. It's wheezing, it's missed school, it's missed work, or it's presenteeism. I'm there, but I'm not at peak performance. If you ask the doctor, it might be airway inflammation, hyperresponsiveness to stimuli of various sorts. But it's a very rewarding disease to take care of.
At what age do people usually get asthma? Can they get it at any age?
You can get it at any age, and this is a misconception. Patients don't think they can get asthma. My oldest patient with brand new asthma is an 84-year-old lady.
Wow.
And of course, her question is, Dr. Jones, why do I have asthma? I don't know that I have that answer. But usually it has its inception in childhood and goes into adulthood, but anyone can get it at any time.
Are there certain things that will cause asthma? Infection, allergy, environment, occupations?
Absolutely. So in an adult, new onset asthma, I always think, what is your occupation? What do you do? What are you exposed to? In adults, I often see asthma start after an infection, a sinus infection, the flu, influenza illnesses, these type things. In children, a lot of time it has its inception in allergic diseases. So we see patients go from eczema, which is a rash, an allergic rash sometimes, to food allergy, to hay fever, to asthma.
Now, when somebody has asthma, what's going on in the lungs? Why do people have wheezing and cough?
Yeah. In the lung, there's a lot of inflammation. There's also excess mucus production, and we have twitchy, smooth muscles around the airway that want to clamp down. All to say, the net effect is the airway is narrowed, making it difficult to breathe.
So when the airway is narrowed, do you wheeze mainly when you breathe in, mainly when you breathe out, or can be both?
It can be both, but usually asthma is a disease of difficulty getting air out. And you make a musical sound, a wheezing sound, sometimes audible to the ear, sitting beside a patient, but often we use a stethoscope and listen to the chest and can hear it.
Do people wake up in the middle of the night with asthma?
Yeah, commonly. It's interesting. At night, if you look at asthmatics, they have more airway inflammation, more eosinophil infiltrates at night. And 3 o'clock in the morning is the magic hour. That's when it wakes them up.
When they wake up with asthma, 3 a.m., what do they have to do to get better?
They need a reliever medication or their rescue medication.
So what is a reliever or rescue medication?
That would be a medication like albuterol, a bronchodilator, a short-acting bronchodilator. Take a puff or two, it works quickly to open the airway.
So it opens the airway, relieves the episode of the wheezing in the middle of the night.
Yes, but it doesn't do anything for the inflammation.
Now, so the inflammation is important. Why do people get inflammation? When you say inflammation, what do you mean?
Yeah. Inflammation of the airway, these are inflammatory cells that migrate into the lung. They lead to inflammatory changes, mucosal thickening, which results in narrowing of the airway. But another question is, well, why do they get that inflammation in the first place? Well, allergic triggers, things they breathe in the spring and the fall. A lot of people become allergic to dust mites or animal dander in their home, work environment, but it doesn't have to be allergens. It can be the common cold, one of the most common triggers for enhanced airway inflammation in asthmatic patients. Exercise, the cold, dry air of winter, a number of emotion even can stimulate.
So if somebody thinks they hear wheezing in somebody in their family, or they feel like they hear it on themselves, how do you make the diagnosis of asthma? Is it easy to make or difficult?
Well, it can be both. Sometimes asthma is very easy to diagnose. So first we go through a good history and physical. Do you have an allergic predisposition? Are you prone to hay fever in the spring and fall? After exercise, do you cough and wheeze? Before thunderstorms or after, are you prone to asthma attacks? Or breathing attacks? Then a good physical exam. Do they have allergic shiners, dark circles under the eyes? Do they have the pale blue nasal mucosa that we see? Sometimes nasal polyps in those patients. And then, of course, a good chest exam. Do they make abnormal breath sounds? Do they wheeze as they breathe in? Now, there are other things that can make us wheeze. So we've got to do a good heart exam to make sure everything's okay. A good upper airway exam to make sure there's not something there making them wheeze. After we do that, we do some tests, allergy tests commonly, to look for allergic triggers to assist them with avoidance. Avoid the things that you're allergic to and your asthma does better.
So far here, I can see it's a very organized history and physical, and now we do skin testing to identify if we think allergy is part of the problem. What are some common allergies that can trigger wheezing?
You know, patients are pretty good at guessing, all right? Spring and fall, they do a good job. Cats, they're always right. I'm not even sure why we test them to cat. They've never wrong. For every patient I've ever had, if I'm allergic to cat, is allergic to cat. But there's other things they don't know they're allergic to. Dust mites, mold, cockroach. We need to know. These are common. They're more important in certain populations, maybe in inner city or children, but dust mites for all of us are bad for asthma.
So when you identify that, how do you identify whether they're allergic? With skin testing?
A skin test, and that's a simple test with a plastic device, takes 20 to 30 minutes to do, and the vast majority of patients, wow, that was simple. I should have done this years ago. Yes.
Now, are there tests, can people have asthma and you don't hear any wheezing? Are there tests that you can test the lungs to see how the lungs are doing to see if there's asthma?
There are a number of tests you can do. And now asthma, when you say, are they wheezing? Well, some asthmatics wheeze, some asthmatics cough, and there's a big spectrum of symptoms. It's not just one presentation for asthma, but cough to wheeze to shortness of breath or all extremes. The two tests we like to use for this, one is spirometry. That's where you blow into a machine to see if your lung function is normal.
What will it tell you if you've got asthma? What does spirometry tell you?
Spirometry, there's certain parameters or numbers we look at, and if certain numbers show that there's narrowing of the airway, that shows you have an obstructive narrowing lung disease. Now, the most common would be asthma, but there are other diseases that do that too. So what we'll do is we'll give them a breathing treatment with that reliever medication, albuterol, and repeat the test. If it improves significantly, certain parameters there too, then you can make a diagnosis of asthma. But even if it doesn't reverse, it still might be asthma. Even if it's normal, it still might be asthma.
Now, if you tell somebody they've got asthma, does that scare people? Do they think, am I going to die of asthma? Is there mild asthma? Is there intermittent asthma? Is there severe asthma?
It does scare people because they always picture the person who's gasping for air and who can't breathe. I hate the word mild because even a mild intermittent asthmatic can severely flare and end up in the emergency room, the hospital, the ICU, and on a ventilator. So I avoid using mild with patients. But I like to take advantage of moderate to severe because they hear that and they understand, ooh, Dr. Jones says this is moderate to severe. I better take this seriously. I better use my medications. I better take my time and take care of myself.
Is there good treatment for asthma?
Excellent treatment. We have more options than we've ever had.
And that's what we're going to be talking about when we come back. More options than we've ever had. Excellent treatment for asthma. You want to stay tuned. We're going to find out what those treatment modalities are. We're talking with Dr. Phil Jones, board-certified lung specialist, board-certified allergist. We're talking about asthma, a condition where the airway goes into spasm, and there's also inflammation of the airway, causes cough, causes wheezing, causes shortness of breath, frequently occurs in the middle of the night, or can be when you're exposed to certain allergens or infection can cause that. And the treatment is better than we've ever had. Is that a pretty good summary so far?
Absolutely.
So let's talk about if somebody has an asthma attack. What do you mean by that, and how do they treat it?
An asthma attack versus just chronic asthma symptoms of some cough, congestion, wheezing that is not necessarily distressful. An attack is very distressful. The airways clamp down, they can't breathe. If you ever had a sensation where you couldn't get your breath, it's very distressing to a patient. So all asthmatics have to have a rescue medication, an acute reliever that works quickly.
So a reliever, a rescue medicine, what are you talking about?
These are medicines like albuterol. And albuterol is a short-acting beta agonist that we can take 2 to 4 puffs depending on the severity of the attack.
So it's an inhaler.
It is an inhaler.
Do people know how to use inhalers? You have to spend a lot of time talking to them.
Yeah. Part of treatment of asthma is education. In fact, it's probably a significant part. They have to know what this medicine does, how to use it properly, and why they need to use it as instructed.
So if somebody is having an attack, they can't breathe, they feel smothering, and they know they've got a reliever, how long does it take the reliever to work?
Very quickly. 2 to 5 minutes, we should be seeing some improvement in symptoms. Okay. Now, I'll often tell them if they had, we go back to our patients, 3 a.m., I'm woken up, I'm distressed, I can't breathe. 2 to 4 puffs, wait 15 minutes. If you're still having trouble, 2 to 4 more puffs, wait 15 minutes, still having trouble, we'll try one more time, 2 to 4 puffs. But at that point, it's time to get to the emergency room.
So it may be that you don't respond to the reliever and there's a plan to get to the emergency room. Okay, somebody got through the attack, but they still have the diagnosis of asthma and they still have problems in the middle of the night, or they have problems when they're exercising. What else can you do? You mentioned the word inflammation. How do you treat that?
Yeah. So there's some people with intermittent asthma. There's some patients with persistent asthma. The persistent patients need the reliever, but that's not going to fix the inflammation. They need anti-inflammatory medications. We have a number of those. We have leukotriene receptor antagonist, which is a pill.
Leukotriene antagonist receptors?
Yes.
Yeah. Okay, like what?
Like Singulair or Montelukast.
Will they help?
They will help, but it's not your go-to first-line medication. It's an add-on therapy. The kind of the cornerstone for treating a persistent asthmatic patient, the drug that you build around are inhaled corticosteroids.
So what does the inhaled corticosteroid do to the lungs that helps chronic asthma?
That medicine is taken in a variety of devices. Okay, there are discs, there are various modes of delivering this. So that's key. You've got to know how to do that. But you breathe that medication into the lung, it has an anti-inflammatory effect, shrinks that mucosal thickening, decreased mucus production, decreased infiltrate of eosinophils.
Does it make it where the lung is less twitchy, where you don't wheeze as quick?
Yes.
So that's a key to long-term. Are there a lot of people that are not on inhaled corticosteroids?
There are. So asthma is often under-recognized, under-treated, but there's other things that complicate asthma management. Cost of medications. It's one of the biggest things that interferes with asthma control. But right behind that is non-compliance, which means the patient has access to the medication but chooses not to use it.
So people can use their inhaled corticosteroid, they get better, it takes away the inflammation, they feel good, so they stop using it.
It's human nature, and you see it over and over and over, but that leads to recurrent symptoms, recurrent flare-ups, exacerbations.
So if somebody has a reliever and they have an inhaled corticosteroid and they can take Singulair, do you have any other medicines? Do you have combination of the two?
Yeah, there are combinations of medications. So sometimes if we're not doing well on a inhaled steroid, we'll increase the dose. We'll add that leukotriene receptor antagonist we talked about. We might add one of 2 drugs at this point. We used to just think about LABAs, long-acting bronchodilators, but now there's LAMAs, long-acting antimuscarinic agents like Spiriva, which is now, we've always thought of it as a COPD medicine. Now it's approved for asthma. So we have a choice.
So
You
we're
don't have to
getting
go to-
more and more choices for people that have chronic asthma that's not under as good control as they want. And so you have a long-acting bronchodilator, and you have a long-acting Atrovent-like medication.
Correct.
And those help prevent somebody from wheezing chronically.
Absolutely.
How often do people have to use steroids by mouth? And if somebody's having trouble with their lungs, how can you get them better if they're not responding to those other medicines?
So if they're on a good regimen and they have a flare-up, sometimes we have to use oral prednisone, which asthmatics and the lungs, they love it. It's good. It opens them up. It's cheap. And that's the problem. But it has a lot of potential side effects. Used frequently or chronically, we're looking at osteoporosis, cataracts, glaucoma, bone loss, adrenal gland suppression, immunosuppression. So long-term, it's a bad fix for asthma.
So if we can keep away from long-term steroids, prednisone, do the inhaled steroids cause those problems?
No, not in general, okay? Those medicines used appropriately and the doses we use them at, it's very low risk for any of those things to happen.
Do people's nose allergies bother their lung allergies?
Absolutely. I tell patients every day, multiple times a day, if this isn't happy, this isn't happy.
So how do you get this happy?
You have to know what's going on in there. Is it allergies? We do the allergy test. Is it sinus disease? Is it nasal polyps? Is it aspirin allergy? There's a lot of things that contribute to that. But we've got to do everything we can. It's just as important to get this healthy as it is this in an asthmatic.
So the things that can cause the nose to be causing trouble would be allergy, or you said polyps,
Yes.
or you said sinus infection. So how do you find out if they've got those things?
Yes. Well, allergies, we've talked about the allergy
Skin
test
testing.
or time or two. Easy, that gives us a quick answer to that. Sinus nasal polyps, you can often see just with looking in the nose. Sometimes we do rhinolaryngoscopy, a camera where we look through the nose and down to the voice box to see if you see polyps. The sinuses, sometimes you can see with a scope, but sometimes you have to do an x-ray, a CAT scan of the sinuses. It lets us know what's going on in there. And it's not always infection. Sometimes it's chronic inflammatory sinusitis.
While we're talking about polyps and asthma, there's one triad that I don't want to get through the show without mentioning. Samter's triad, what is that? That's polyps?
Correct. Nasal polyps, asthma, and aspirin hypersensitivity or allergy to aspirin.
Is that dangerous?
Very dangerous. Those patients have very acute bronchospasm to exposure to aspirin or other NSAIDs, but you can desensitize them to that and it improves their polyps and their asthma control.
So there are things you can do, but you have to be aware of it and you have to look at it.
Yes.
Do you warn people about taking aspirin if they've got asthma?
You know, usually in talking to the patient, patients take aspirin or NSAIDs so frequently, you can get a good feel. So usually we know ahead of time that they don't have it, okay? But if time and history tells us, so I don't routinely advise asthmatics to avoid it. It's only about 10% of asthmatics. But we've got to think about it and watch for it.
There are some newer medicines called biologics, and we've only got a minute or so. What do they do? That's if you've got the other medicines and you still need a little extra help, what are some of the things we can do?
We're really excited about these. We finally have biologics in our asthma care. Xolair is a monoclonal antibody against the IgE receptor. It decreases asthma attacks, steroids, emergency room visits, quality of life, all the things we would like to see in our asthmatic patients, administered by injection. We have newer drugs. They're monoclonal antibodies against IL-5, which is an inflammatory promoter in an asthmatic patient. So it takes that out of the picture, decreases airway inflammation, exacerbations, improves their pulmonary function, those type things.
With all the new medicines we've got and identifying triggers and getting the patients to use their medicine, what is the outlook for asthmatics?
It's better than it's ever been. They should expect a normal life, to do all the things they want to do. Asthmatics seem to accept that I have asthma, I can't do what everyone else does. They don't need to do that. They need to get treatment, do all the things they want to do.
Phil Jones, what a teacher you are. I've really thoroughly enjoyed this show. Thank you for giving us the information of how serious asthma can be. There are excellent medicines that are available where people can live a normal life.
Absolutely. Thanks for having me.
Yeah. What a great discussion. You're going to want to stay tuned. We're going to be talking about increased incidence of cancer of the colon in young people. and also causes of chronic cough. A lot of information for you. You'll want to stay tuned. I want to thank Dr. Phil Jones. A wonderful discussion on asthma and how to treat it, and knowing that the outlook is good. Now, questions from you, the viewer, that I think will be important to your health. Question number one, Dr. Bob, at what age do I need a colon exam? Well, let's talk about colonoscopy. Normally, the recommendations now, if there's not a strong family history of early cancer of the colon, that we start at age 50 and we get a colonoscopy. What we're looking for on a colonoscopy is polyps, because we know that polyps will slowly grow over time, 2 to 3 years perhaps, into cancer of the colon. So if we get the polyps early, we can remove those. Now, at age 50, if you don't have any polyps, then the doctor will guide you as to how frequently you should have a repeat colonoscopy exam. Big problem. Brand new, recent information. Millennials, young people, there's an increased incidence of colorectal cancer, cancer of the colon and cancer of the rectum. So should we start at age 50 with the first colonoscopy? Should we start earlier? Why is there an increased incidence? Is it diet? Is it lack of activity? Is it something we're doing? We've got more learning that we have to do to find out what that is. But I think we need to be sure that on our 50th birthday that we do get colonoscopy, and perhaps even you may need to get that earlier. Be sure and discuss that with your doctor. Cancer of the colon, if we find those polyps, we can keep cancer of the colon from occurring. So be sure that you take good care of your colon, that you keep that healthy, and especially just because you're young, know that time to start is early. Good luck on that. Be sure that you see your doctor and discuss that. Question number two. Dr. Bob, I have a chronic cough. What is the problem of a chronic cough? Well, let's talk about a chronic cough. Let's say one that's been going on for at least 6 to 8 weeks, 2 months of a cough. It's a relentless cough. We have to take a history. We have to find out what the cough is like. We have to find out if the cough is a rattling, wet cough, an infected cough, if we're coughing up any sputum. What makes that cough worse? Is it cold air? Is it certain triggers? Is it allergies that are causing the cough? But let's go through causes of cough. The first thing we always think of is drainage. Now there's a reflex on the back of the nasopharynx, the back of the throat. There's a reflex, so people that have drainage can irritate that area, and that can send a reflex to the brain that says, cough. So there's a reflex on that. While we're talking about the nose, sinus disease. There's also the same type of reflex that goes to the brain that says cough. So we have to think of the nose. We have to think of the sinuses as a problem that can cause chronic cough undetected. Reflux disease, gastroesophageal reflux disease, GERD. GERD can cause cough 2 or 3 different ways. Number one, it can come all the way up to the top of the throat, the reflux can, especially if you're laying down in bed, and that can irritate that, send a reflex, and can cause cough. Or the acid that's refluxed can go down on the epiglottis in the area where we can have cough, or there's a reflex from the bottom part of the esophagus. So we have to know about drainage, sinus disease, reflux. ACE inhibitor medications. There's a blood pressure medicine called ACE inhibitor. Probably the most common cause of dry, relentless cough. If we stop the ACE inhibitor, we have to be off of it for at least 6 weeks before we know if that was the cause of cough. There's 5 or 6 different families of blood pressure medications, so we can go on other types of medications. There's a cough variant of asthma. Some people that are not wheezing like we talked about on the show, but people that just have a dry, relentless, irritative cough. They may be having some underlying cough variant of asthma. The lung studies, the spirometry can pick that up, or to see if there's a sensitive airway, we can actually induce somebody to have wheezing. If we induce them at an early stimulus, it makes the diagnosis there. Other causes of cough: cigarette smoking. If you're a cigarette smoker, it's time to stop. We know that it damages the heart and the blood vessels, and so it can certainly be the cause of a chronic cough. It's usually a rattling cough. It's usually a productive cough, but it's a common cause of a relentless cough. Abnormal chest x-ray. Some people that have a spot on their lungs, that could be irritating the airway and could be a cause of a cough. So know that there is a workup for a cough. You and your doctor can work through a plan and should be able to get that chronic cough to go away. Now, that's all the time that we have for this show. Hope you've enjoyed it as much as I have. Remember those 4 things that we like to do? First one's exercise. Exercise will keep you happy. It will relieve stress. It will make you lose weight. It will make you feel better. You'll get a runner's high and you'll perform better. Get 7.5 hours of sleep. If you're not sleeping well, find out the cause. Is it pain? Is it your medication? Is the room not nice and dark and ready to sleep? Because we need that 7.5 hours of sleep. Be sure we're eating properly. Be sure that the food we eat is proper food. More fruits and vegetables, less fatty foods, no fried food, no greasy foods. And most of all, what is it that we like in that Dr. Bob Show? It's that laughter in your life. Find somebody that you love. Laugh a lot with them. You know, when you laugh a lot, you'll be happy. The people around you will be happier. You'll not only be happier, but you'll be healthier.